Good morning, everyone. I think we'll get started in a timely manner because I suspect we'll be anxious for more time towards the end. I'm Lisa Studdert and I'm the Manager of Policy and Programs at the Australian National Preventive Health Agency. I want to start by acknowledging the Ngunnawal people on whose lands we are meeting today, the traditional owners and custodians and their elders past and present. It's a great honour for the National Preventive Health Agency in conjunction with the University of Canberra to host this forum today. I think from all I've heard, it's going to be a very exciting presentation and we'll all be greatly inspired to do great things after this in our own town and around the country. From ANPHA's perspective, it's highly appropriate as the national agency established to promote and support chronic disease prevention efforts in the broader realm of our community and in partnership with many of the people that are represented here today. And in case you didn't get a feel for it, we really have been delighted by the response we've had to coming today. We've got people from many departments here, government departments, non-government agencies, and many from outside of the health sector. So I think that's exactly exemplifying what we want to try to achieve in our thinking and in our partnerships as we take this very important subject and act on it. There's some great champions from the Canberra community here today, and it's always risky to name a few, but I know Greg Muse from Heart Foundation with support from the ACT government and their Active Living program, Gwyneth Lee, who launched the beautiful exhibition last year at the Gallery of Australian Design on design innovations in Australia. Thanks for coming today, Gwyneth, and from the Institute of Landscape Architects, and no doubt many others of you here who've been actively involved in this subject. I had a chance to look at the guidelines last night and they were very exciting that we'll hear a bit more about. I was a bit embarrassed by the great swathe of content there about stairs and using them and placement. At the Australian National Preventive Health Agency, we have to admit we're on the first floor and have no access to the stairs to get up to it and down from it, so it's always a little embarrassing when we have to stand at the lifts. I was very amused by the note you have in the guidelines about the long history of active living design in New York City, including the fact that Central Park in its original form was designed as an outdoor living area to address the tuberculosis and cholera epidemics of that time. And of course that's a great legacy to public health to this day, which makes the city the stunning place it is for many of us when we visit there. I'm greatly delighted now to introduce Karen, who's come to us from New York City, but as she just reminded me, originally from Canada, and we have many Canadian friends, including ANPHA's CEO, so it's great to have that connection. Karen currently heads the Built Environment and Healthy Housing program at New York City in the Department of Health and Mental Hygiene, which of course many of us know as being one of the great public health champions in the world today, not least of all in the recent ban that got a lot of publicity around the world of the big sodas, and we're certainly looking at that closely here in Australia. Karen is a medical doctor and also an adjunct professor at the Schools of Public Health at the Universities of Alberta and Toronto. I read with interest that Karen was previously with the Epidemiological Intelligence Service of the Centres for Disease Control, the very famous shoe leather epidemiologists, which many of us have looked at with great admiration over the years. As the author of the Active Design Guidelines, it's really a great pleasure to welcome you here today, and we look forward to hearing from you. Thank you, Karen.
Okay, so with that, I think I'll start my presentation. And I think as Lisa mentioned, I think the Active Design Guidelines and all of this work around healthy built environments in New York City really are reflective of co-leadership actually across different sectors from the very beginning. We actually began this work in New York City. I was at the Centers for Disease Control doing this work, helping interested states in the US, 9-10 years ago on this work. And then New York City actually wanted to start, New York City's health department wanted to start addressing some of these issues because of the evidence base that had grown behind them at that point. And so I was recruited up to New York to start this work for them. And we really began this work immediately. We began it with a brainstorming conference with the other sectors at the Center for Architecture. And so from the very start, it was really a cross-sectoral type of collaboration. And I think that is the very reason that we've had the types of successes that we've had, both in the policy and in the practice realms. It's because it's grounded in the reality that our other sectors bring to these issues. So with that, I'm just going to move into the presentation. So I want to start by saying, going back to history, I think, a little bit. If we look at the public health issues of the different centuries, in the 19th century and early 20th century, the leading causes of death, infectious diseases. And the way that we actually addressed those diseases was through our 19th century codes, planning, design, and infrastructure. And we built them into our city's fabric, and they were effective. And this isn't just in New York City, but if you look at the history, I think, of the origins of most of our cities and where our public health issues were and where our public health successes are. In the 21st century, we've got actually a different set of diseases, chronic diseases like heart disease and strokes, diabetes, cancers, and risk conditions like obesity and tobacco. And many of these diseases actually can be thought of as diseases of energy. Obesity, for example, and its related consequences are actually diseases of energy. In that too many calories in the form of unhealthy foods and beverages is an energy source. Too few calories out is fundamentally also an energy equation. Now, because of that energy link, actually, there are the solutions for obesity and the issues of healthy eating and physical activity actually have implications for other energy matters. And because of that, design solutions actually related to those energy matters actually parallel design solutions for environmental sustainability. And so I'll talk about that during the presentation. And if we're going to learn from public health history, in order to be effective, we have to make these designs a pervasive and a part of everyday life. So again, going back in history, this is New York City, but it actually is, it typifies many of the urban conditions that many of our cities started out with. In Lower Manhattan, severe overcrowding in 1910, about 114,000 people per square mile compared to 67,000 people per square mile today. That's about double what it is. In some of the wards, it actually reached over 400,000 people per square mile, so 6 to 7 times what the densities are in Manhattan today. Coupled with that, inadequate systems for garbage, water, sewer, leading to pervasive filth and polluted water supplies. If you read some of the history about Manhattan, you'll hear about the drinking water coming from a pond downtown. That pond was described as frequently having garbage and dead animals floating in it, right? The streets were dark and dank because buildings were set really, really close together, so light and air couldn't penetrate into the streets. Then you had these damp puddles that would breed mosquitoes. And so the types of, you had tenement buildings that had no windows and with very crowded living conditions. So the types of epidemics that we saw during that time were diseases spread by crowding and lack of ventilation, tuberculosis, diseases spread by water, cholera, diseases spread by mosquitoes, yellow fever. So what did we do? Well, the response was very much an infrastructure one. We didn't have antibiotics. We didn't have many of our vaccines. So the city, after multiple cholera epidemics in 1842, established the Croton Aqueduct, which is the new reservoir in upstate New York. It continues to serve us today. Soon as this aqueduct was established, those cholera epidemics went away and they never came back. 1857, Central Park created and hailed as ventilation for the working man's lungs. So now, if you're not wealthy and you didn't have your own little courtyard, you can still go to the park to get fresh air and to enjoy the sunlight. 1881, Department of Sanitation was created and started cleaning city streets of dead animals that would be left there, horse manure that would pile up, all the garbage on the streets. And in fact, for those of you who've been to New York City, you may have seen the brownstones with their elevated entrances. Well, one of the reasons the entrances are so elevated is because back in the day, before the Department of Sanitation, you actually didn't want to live on ground level if you can help it. 1901, the Tenement House Act was passed and actually banned the construction of dark, airless tenement buildings. So now, all of a sudden, All buildings, including low-cost housing, had to have windows. Light and air entered. Circulation was made possible. 1904, first section of the subway opens, in large part to address that severe overcrowding in lower Manhattan. So now people could suddenly live in northern Manhattan in the Bronx, travel quickly down to lower Manhattan for commerce and for work. 1916, zoning ordinance was passed requiring buildings to be stepped back from the streets. Now all of a sudden, light and air could enter your streets, those puddles dried up, the mosquitoes went away. So what did we see? This is exactly what we saw. Infectious disease mortality dropped from approximately 60% of deaths to 11% of deaths by 1940. This was before the widespread use of antibiotics. Penicillin, the first antibiotic, not discovered until 1939, not in widespread use in 1940. All the other antibiotics, not yet available. Between 1940 and 2011, what do we see? We see a continued drop in deaths from infectious diseases, but from 11% to 9%. And of course, most of our medical technologies have been garnered from between 1940 and 2011. So this is to say that it is not medical treatments that will determine the types of epidemics that you see. They are a critical part, of course, of addressing diseases once they occur, but the prevention of diseases is key, and the prevention of diseases actually is fundamentally shaped by the environments that we design, we construct, and that we have to live, work, and play in. So of course today, a different set of diseases, chronic diseases, diabetes, heart disease and strokes, cancers, risk conditions like obesity. Chronic disease is now the #1 cause of death globally. According to the World Health Organization, 36 million deaths per year. The situation is in fact so dire, and concerns about costs related to these diseases, both healthcare costs and productivity costs, are so high now that the UN actually devoted one of its General Assembly summits to focus on these diseases. So in 2011, in their meeting in New York City, the focus of the whole UN meeting was actually the prevention and address of non-communicable diseases, chronic diseases. The leading causes or risk factors for these deaths, for these chronic disease deaths, are actually tobacco, physical inactivity, unhealthy diets, harmful use of alcohol. Now, the two red items, physical inactivity and unhealthy diets, very much, as I said earlier, linked to this energy equation, and because of that, the implications we'll talk about in a little while. Now, we think of many of these risk factors, tobacco, inactivity, unhealthy diets, harmful use of alcohol, as individual lifestyle factors. But in fact, the evidence has played out over the last decade and two from all of the research that has now been done that the environments, again, in which we live, very much shape people's ability to actually choose and maintain these healthier lifestyles. Some of you may have seen these maps from the U.S. Centers for Disease Control and Prevention. In 1985, the U.S. CDC began collecting data across states through an annual survey of adults, asking them various questions about their health, about the health conditions that they might experience, and also their heights and weights are collected as part of that survey. And heights and weights are then taken and calculated into a body mass index. Body mass index of 30 or above is considered obese for adults. So in 1985, when this all began, you could see that there was no state above 14%, and that stayed the case until 1990. By 1991, we've got a new color above 15%, and you'll see this change extremely rapidly. By 1997, 20+%. And it doesn't stop there, actually. You will see that it continues to grow. Vast majority of states above 20% now at 2001, new color. Of course, it doesn't stop there. So that by 2009, this is what we have. The vast majority of states above 25%. Colorado, the only one under 20% now. No state below 15%. And many states above 30%. And with that, type 2 diabetes has grown tremendously as well. And in fact, are now seen in children and teenagers and young adults, whereas previously, when I was going to medical school, they called type 2 diabetes adult onset diabetes because you rarely saw it in people under the age of 50. And so with that are all of the implications of complications that come with time living with diabetes, including amputations, blindness, kidney failure, needing dialysis and kidney transplants. And of course, if we're seeing this in younger and younger people, all these complications, there's not only the health care costs, but the implications for, I think, workforce productivity, disability, a lifetime of disability. So many implications, and of course, healthcare costs. Medical costs attributable to obesity now in the US are about $150 billion a year, and that's excluding all of these productivity costs that we're talking about. Trends and projections suggest that if the obesity trends, the epidemic that you're seeing, continues to rise at the rates that it has, the costs by 2030 are going to be about $1 trillion a year in healthcare costs. Now, already in the US, healthcare costs are taking up about 16% of the GDP. So, often I think one of the things that we frequently hear, for example, in the media is it genetics or is it our environment that's determining some of the epidemics that we see? Well, I hope that, from both the history of public health and from how rapidly you've seen these epidemics grow, that you're convinced it's not our genetics that have changed in essentially 2 to 3 decades. But if you look around us, our built environment certainly has changed a lot. It's very easy now to go through life and not have to expend actually any energy. Not have to, we no longer walk or bicycle to our destinations. Our children very frequently no longer walk to school. We walk into a building, and it used to be that you'd have a beautiful stair. If you have to go a few floors, you would traverse it by stair. Now you don't know where the stairs are. They're potentially locked. If you can find them, they're way in the corner, dark and dingy. And what faces you is an elevator or an escalator. And then, unhealthy, high-calorie foods and beverages with no nutrient values are basically everywhere. So, in New York and in the US, our newsstands used to sell newspapers and magazines, and now they also sell, about half of their space is probably taken up by potato chips and candy and chocolate bars and, sugar-sweetened beverages like soda pops. So I talked about how over the last decade, particularly, and into 2 decades, there's been a lot of research. So funders of research have basically been, funding research to try to help us look for solutions to these epidemics. Researchers have responded. There's been, mounting evidence, and in many cases now strong evidence that we can actually impact health and these conditions through how we design our buildings, streets, and neighborhoods. So a very key part is designing to increase active transportation. With people's busy lives, it is very difficult frequently for them to maintain having to set aside an extra half hour or hour to go to the gym every day for leisure time activity. If we can build physical activity into people's daily lives as part of their commutes, then it's done. It's done. 5 days a week, 30 minutes a day, they've gotten their physical activity recommendations met. For children, it's 60 minutes a day. So that would probably involve both walking and cycling to school, but also, physical education while they're at school. If we can build that into everyday life, then we're a long ways ahead in terms of getting some of these issues beat. So, designing to increase walking, bicycling, and transit-oriented development. So what does that mean? That means having sufficient density, I think, in our residential areas so that you can combine that density with services that will be supported by a sufficient population. Services nearby means that you can walk to those services as long as you have footpaths that are safe and accessible, as long as you have, if it's a little bit further, cycle paths that are safe and accessible. Once you get to those destinations, you'll probably need bicycle parking. If it's pleasant as well as safe to get to those destinations, you'll probably more likely want to walk. So if there's nice landscaping, street trees, urban art along the way, if the building and elements are actually of pedestrian scale on your street route, and designs like that, according to reviews by the Centers for Disease Control and Prevention in the US, they have a task force on community preventive services who undertakes these reviews routinely. Their conclusion is that there is a good evidence that these types of strategies will increase physical activity in daily life 35 to 160%. Then we can also design to increase active recreation and leisure time. So there are now many studies, strong evidence that if you enhance places to, enhance access to places for physical activity, such as walking trails, parks, playgrounds, exercise facilities nearby to where people live and work, it increases exercise and activity in both children and adults and is associated with better weights. Designing to increase stair use. Some people have said, oh, what can a little bit of stair use do? Well, you know, in the United States, physical activity experts have done caloric burn calculations and estimated that if the average American adult was to climb an extra 2 minutes of stairs per day, we would be able to eliminate the average weight gains that we see in US adults. So very little things done in everyday life, really important. That's actually a Harvard alumni men's study. They followed over 10,000 Harvard alumni men over a 13-year period. They asked them about all sorts of their activities during daily life. And then they looked and see over that 13 period what sorts of health outcomes, disease outcomes developed. And they found that the men who climbed on average 20 to 34 floors of stairs per week, if you divide that by 7, that's only 3 to 5 floors per day, they had a 29% reduction in their risk of stroke. And that's independent of whether they exercised in their leisure time. So that is to say that daily things done, small bouts of it in everyday life, are actually really important ultimately to shaping our health outcomes over our lifetime. And there are now a whole host of studies about increasing stair use. You know, simple, as long as your stairs are accessible, simple decision, point-of-decision signage placed at elevator call areas outside of stairwells that tell people to take the stairs for health and other benefits will increase stair use, there's many, many studies now, by on average 50%. Design and aesthetic interventions. Just like we want our streetscapes to be pleasant to walk in, a stairwell that's pleasant to use because there's music, there's art, there's bright colors, will increase stair use. If you can actually see the stairs when you walk in, and so it's convenient, it's visible. If you're going a few flights, people are more likely to use them. And of course, you know, some folks may not want to climb 30 or 40 stories in our very high-rise buildings, but there are some things called skip-stop elevators. So elevators can be programmed to not stop at every floor. They can stop at every 3rd or 4th floor, except for one elevator for people with disabilities. And in fact, studies have been done in some buildings like that. For example, in California, there are, in New York as well, there's been some buildings built like that. And those studies show a 3,300% increase in stair use in those buildings. Something like 70% of people in those buildings use the stairs every day. At the same time, we need to also think about our food environments, which is the other side of the equation. Food retail environments are a really critical piece. There are more and more studies now showing that supermarket availability are associated with lower rates of neighborhood obesity, with better eating. There are even some studies. There's one in Leeds, UK, and they opened a neighborhood supermarket in their inner city neighborhood, and they did before and after studies. And they actually found that people also walked more after the new supermarket opened, because now they had an extra destination that they would routinely walk to buy their food. On the converse side, a high density of fast food restaurants are associated with increased weight and obesity in both children and adults, also with less healthy eating. Community gardens. Community gardening, you know, it may not be able to provide us, I think, with the access that we need currently to all of the fruits and vegetables for a community's needs, but there's some emerging evidence that exposure to community gardening may increase fruit and vegetable consumption for both adults and children. And then on the beverage side, you know, caloric beverages like soda pops, et cetera, actually contribute to a very significant amount of calories, for example, in the US diet. 10 to 15% in both children's and adults' diets. These things basically just give you calories, they're empty. And when you drink your calories, it's actually particularly bad because you don't feel full. And so you might have ingested 1,000 calories worth of drinks and not feel full. And that's because the whole process of actually eating and chewing and swallowing your food is part of the process of feeling satiated by food. So that's excluded when you're drinking your calories. There is a study of elementary school children actually in Germany. And they looked at actually high poverty neighborhoods and had intervention schools where they actually ensured that the water fountain was working, or they installed water fountains if it wasn't working. They did a little bit of education with the kids about drinking tap water. And then they had these control schools that where they didn't do anything. And they found that over a period of some years of following up these kids, the kids in the intervention schools with tap water access and promotion showed lower weight gains over that time period compared to the control schools. Now, in addition to all of these health benefits, there are actually benefits for the environment. And of course, that comes down to that energy equation that we talked about earlier. So if you, the most commonly voiced items related to this would be, active transportation, walking, cycling, taking transit rather than the car. Has implications for air quality, for fuel and fuel use. But all of these other parameters we've talked about actually also have implications. So for example, if you use the stairs rather than elevators or escalators are actually electricity using devices. So whenever we don't move ourselves, we're actually relying on some type of external energy source and generating carbon because we need those energy sources to move us. I read a statistic actually that said that an escalator running 24/7 can actually generate as much as 4 carloads of carbon dioxide per year. So it's not insignificant. On top of it, I've heard from building maintenance people that they constantly break down. So they're actually really expensive to maintain. So there's, really not many reasons for having escalators if you can avoid them. Active recreation rather than television viewing. Television viewing associated with obesity, particularly in children. Research suggests that it's not merely actually the physical inactivity side, but also on the other side is, eating high-calorie foods potentially while they're watching television. So when you're actively playing, you're not usually eating. And the other piece is exposure to food advertising as children are sitting there watching television. Now, TVs in New York State on the energy side very soon anticipated to overtake refrigerators as the main source of household appliance energy use. And of course, in summer months, when families are sitting there watching television rather than outside playing, not only is the TV running, but the air conditioning is like at full blast. And this is a major concern for energy usage that leads to blackouts in US cities. So there's these synergies, and therefore affords us an opportunity potentially to work with folks who are concerned about the environment on some of these issues because we share some of these common solutions. Safe tap water access rather than bottled and canned beverages. So often we hear that environmental argument about drinking tap water versus bottled water because bottled water has all these transportation miles, the bottles go into the landfill. Well, those bottled and canned beverages that are highly caloric also come in bottles and cans. I suspect that the transportation miles may actually even be worse because not only is there water in those bottles, but there's all of those ingredients that were initially raw, had to be shipped to be processed, then had to be reshipped to be bottled. And then, of course, all of those bottles and cans also go into the landfill. And then similarly, if you think about eating fresh, healthy food rather than really unhealthy processed foods, fresh foods, like fresh fruits and vegetables, leave very little waste. And the waste that is left is compostable. If you think about the highly processed foods that are usually high in sugar, fats, salt, they usually come very highly packaged and highly processed, right? So the transportation miles as well as the landfill packaging, the packaging that goes into the landfill is there. The other co-benefit is actually creating more accessible places for people. As our populations age, for people who have disabilities, a very walkable realm that has great footpaths with sufficient width, with good surfacing, with safe crossings on the streets. These are all things that actually make the public realm more accessible for people as they age, for people who have disabilities. And similarly, our Mayor's Office of People with Disabilities, who are involved with us in the Active Design Guidelines, pointed out that even promoting stair use amongst able-bodied people is good for people who have disabilities who have to use the elevator. Because a very crowded elevator, as you can imagine, is not very easy to use for someone who's in a wheelchair, who has a walker. And so freeing those up, actually, are a piece of improving accessibility as well. And then there's a lot of cost-related benefits also. And this is something that, you know, politicians care about in every community. Sprawled infrastructure scenarios for both construction of infrastructure and maintenance of that infrastructure as it ages, much more expensive than more compact, dense developments. Households, particularly in times when economic times are harder and on a social equity basis. This study basically in the American context showed that people who lived in walkable transit-rich neighborhoods where they have options to walk and take transit spend on average 9% of their monthly incomes on transportation, compared with those living in completely auto-dependent neighborhoods where they're spending like 25% of their monthly incomes. Also, job creation. In job creation? Yeah, job creation. So creating road infrastructure for cars alone actually creates fewer jobs per $1 million spent than road infrastructure that includes bicycling and pedestrian infrastructure. Now, part of the reason for that is that road infrastructure for cars alone usually is for sprawled infrastructure, which means that a lot more of your money goes into land costs as opposed to costs of a more intensive infrastructure on any given mile of road. That more intensive infrastructure then creates the jobs needed to actually build that infrastructure. All right, so with all of that background, I want to now turn to, you know, integrating health and the issue of lessons learned for integrating health into urban and building design policies and practices. So if we're going to do this, for those of us working in health, we really need partnerships across the other sectors, because of course we don't design or build our environments. But you know, we do know what the data tells us in terms of the trends that we're seeing in risk factors and diseases. We do know what the evidence base tells us in terms of the scientific studies that are now available and showing us the evidence of what needs to be done. But if we're going to actually have an impact, then we need to reach out to those from other sectors to assist us with taking what's available in that evidence and to identify for us where the opportunities are for actually making a difference within their sectors, within architecture, within landscape architecture, within urban design, within urban planning, within the development worlds. And that's in fact what we've done over the last 7 years in New York City. Health has played a key role in, as I said, outlining the health issues, doing outreach to our other partners, involved in health-related evaluations, involved in actually convening some of the forums for dialogue between the sectors, involved in actually providing staff for some of the cross-sector initiatives where leadership and staff from our other sectors come to the table and also participate. The other agencies, both in the public and private sectors, have basically been involved with us in co-leading some of the various initiatives that have come out of our brainstorming efforts, but also coming up with the ideas in the first place that led to those cross-sectoral initiatives. Identifying for us where the opportunities were in upcoming policy documents, in available revisions that are going to be made to policies or practices within their own agencies or within their own fields, and then co-leading those efforts and initiatives to get things actually changed. Researchers have been a key partner to us in synthesizing and reviewing the evidence that's out there, and when we actually have innovative projects, and helping us evaluate those projects through evaluation research. Using both evidence-based and best practice strategies. And we also have these forums for dialogue called Fit City that have become an annual conference for us. This is where, you know, it's our big public sector public conference where different sectors come together. And we usually have a public panel, a public sector panel, where 9 or 10 of our city agencies will highlight what they've succeeded in doing in the last year and what they plan to do in the upcoming year, so that we keep making progress every year. We have a private sector and community sector panel that talks about all of the non-government great work that's also going on, complementing the government work. And then we actually have a final sort of lessons learned from elsewhere panel, where we bring folks in, or folks who can come in and share with us their initiatives as well, so that we can learn from them also. So June 24th, 25th is our 8th annual Fit City Conference. If any of you are going to be in New York or can make it there, we would welcome you. The second day, we'll have small group discussions and tours, site tours of case examples of the case examples will involve both public realm examples, but also, some building examples and development examples that you may not be able to see if you're there in New York on your own, because it might be like a really innovative affordable housing site, or, a really innovative work site building. I talked about the Fit City conferences. As I said, we began this work really in 2006 in New York with a Fit City conference that brought together all of the sectors to brainstorm together where the opportunities were. Health used that as an opportunity to present its data, to present the health evidence. But we didn't present the solutions because, of course, we actually didn't know what the solutions were necessarily. We didn't know where the specific opportunities were in our local context. And so we very much relied on our other sectors to identify that for us in the conference. We've subsequently used the other conferences for continued brainstorming, but also to give progress reports, essentially, on where we're at with the ideas brainstormed at the previous conferences. One of the ideas that came out of that are the active design guidelines. The active design guidelines, they were brainstormed actually at Fit City 2. We had invited the commissioner, the head of the Department of Design and Construction, which is our public works department. They construct our public sector buildings, and they also construct and design our streets with Department of Transportation. We invited him to be our closing keynote speaker. We were lucky in that he came early enough to hear some of the other keynote speakers from both health and from architecture, talking about evidence-based design. He then said, we do a lot of guidelines, from universal accessibility to environmental sustainability to water efficiency, that we use to guide our public sector construction, that we then also give out to the private sector to encourage best practices in design and construction in New York City buildings and public realms. This seems like a pretty important issue. I think we should create guidelines that would be part of this series of guidelines that we create that would then shape public sector construction to address these issues routinely. And we would then also use these guidelines to encourage the private sector to build in this way in New York City. So we said, great. So after the conference, health and design and construction got together. We then brainstormed, who else needed to be at the table, and we invited city planning and transportation as core partners. These 4 agencies then met every month for the next 2.5 years to get these guidelines done. And now we continue to meet to talk about implementation of the guidelines so that they do not, sit on a shelf collecting dust. So you can see that it has a whole host of strategies. Here's the team. 4 sectors led it: design and construction, health, transportation, city planning. By the time we finished the guidelines, though, it actually had a total of 12 city agencies had given inputs, had written sections. So once the draft of the guidelines were initially done, with the help of actually consultant academics who worked to help to synthesize and update the evidence base for us. Once they were drafted, and then health supplied actually a coordinator and a project manager who worked with me to call the meetings, draft the documents, ensure that these documents were sent out to partners before our monthly meetings, bugged them about reviewing it, bugged them about, we still need that section from you before that next meeting, right? And then basically, and so so after we drafted the document, we actually knew that there were other agencies who would be impacted by various sections of it. And so we sent them out to these 12 agencies and asked them to give input. And in fact, many of them, or all of them, wrote additional things or edited it so that it wouldn't conflict with their policies, or added things that would then enhance their work. So by the end of it, we've got this 12-city agency document. We then actually had a charrette process, which is a design workshop, and invited the most prominent architectural and developer and urban design firms to also come to the table to give us inputs. They gave us great inputs like, there is way too much text and not enough pictures. And so, and where are the case studies? We need more case studies. And we need simple checklists at the end of each of those chapters that our work teams can use very easily without having to read the book. And we actually need a chapter where you specifically highlight the synergies that you pepper throughout the book on environmental sustainability, on universal accessibility, because our clients, like developers, our clients actually ask about these issues routinely. We want that highlighted. So it took us another year of editing, and then a re-review by all the 12 city agencies and sign-off before they came out. Now, that time was well worth spent, because these guidelines, when they came out, no opposition, full support across so many sectors. And it's just been, the response has been really overwhelming. And these folks are really disseminating left, right, and center to their international colleagues, to their national colleagues. So we're finding these guidelines downloaded in, many, many countries by the leading. So when you go to the site to download the guidelines, nyc.gov/ADG, you'll actually see that it asks you to actually list your sector, list where you're from. So there's these required fields so that we can track the downloads. And the sort of biggest group downloading our guidelines are the targeted groups of architects, landscape architects, urban planning, and urban design professionals. And this is what this set of guidelines was meant to target. It was meant to take health-related evidence, put them into a context and into a format that is usable by the people who design and build our built environments. And of course, all of our partners in the other sectors who really helped us create this, created a very usable product that if we in health had done this alone, it would probably be sitting on a shelf with all that text, no pictures and no case studies. And so here I talk about using a combination of evidence-based and best practice strategies. The initial draft of the guidelines before we went into that design workshop with the practitioners themselves only had evidence-based strategies, right? That third category of best practice-based designs, not in there. But during the brainstorming workshop, the practitioners said to us in planning and design, said, we've got all these other ideas for what we think can work. Now, after that workshop, we went back and looked in the literature, in the health literature, to see if there was an evidence around those, and there wasn't. And so we were like, oh, how do we put non-evidence-based items? Because in health, there's this whole notion now of evidence-based practice. And so we came up with the suggestion that, as long as it didn't have evidence against it, let's put it in. Let's put it in, but clearly delineate that it doesn't have the evidence yet, that we need researchers looking at this set of strategies and undertaking research on it. We need research funders funding research on these strategies, because they're in fact strategies that design and planning professionals think can work. So we decided to put it in, but demarcate it. These are the types of strategies, right? Land use mix. If you don't have enough sort of mixes of land use, you can't walk there from your homes, from your work sites. Again, densities and sufficient densities to be able to support those different services close to where people live. As part of the land use mix, thinking about healthy food access, supermarkets, farmers markets, drinking water in the public realm, accessible recreation, parks, plazas, play areas, pedestrian plazas to complement those. Transit access. So in New York City, where we have areas underserved by the subway, we're using bus rapid transit to rapidly expand faster transit modes. And with such initiatives, we are increasing transit use even when there's already very high transit use. Pedestrian-friendly environments, bicycle networks, and infrastructure. Complementary roles for the site and building design realms, parking, bicycle parking and storage when you get to your destinations, very critical part. Particularly in multi-residential, affordable housing, in some of our work sites as well, active recreation spaces within your buildings or within your building sites. Particularly in areas that might be underserved by public parks or playgrounds. Stairs, we've talked about that, improving access to drinking water in places like worksite buildings. So some of the policies that you might want to hear about. Our general approach has been, so our master plan in New York City is Plan YC. Plan YC was actually initially released in 2007. It was re-released in version 2 in 2011. And Plan YC is the master plan guiding several things. One is New York City's population's anticipated growth from 8 million that it is now to 9 million by 2030. With that, of course, are all sorts of implications. Accessibility of housing, of affordable housing. What about our transportation systems? Oh my goodness, is it going to get overcrowded? What about our roads? Traffic congestion is already so bad. If we're going to put 1 million more people, we don't want 1 million more cars on the roads. That means planning for transportation infrastructure that can support other modes. Thinking through quality of life issues. Are people going to have access to open space, to green space, to parks, to playgrounds? So a 10-minute walk for everyone to these sites is actually one of the goals. Now, access to the water, both safe water and preserving our tap water infrastructure, but also access to the water for recreation, for additional opportunities. So anyways, many of these actually overlap clearly with health issues. Now, Plan YC, we were starting this work in 2006 in New York City, as I said, and Plan YC's work was occurring at the same time and released in 2007. And so Plan YC, which is our Office of Long-Term Planning and Sustainability, and Health really began working together at around the same time that this document was released. So in the initial phase, actually, many of these things were already going to improve health, but it didn't specifically call out health as a major element that it could impact. Well, in version 2, once we've begun working with our Plan YC folks, they were like, this is a great opportunity to highlight also an issue, public health, that our residents really care about for them and for their families and for their children. Why are we not highlighting this? So they now put a whole public health chapter in there and has had health be a running theme basically throughout version 2 of the book. Smart growth, of course, very important, transit-oriented development, building up nodes of residences and commercial properties in a mixed-use way around transit nodes and with sufficient density. For those of you who've been to New York City recently, you would have seen the public right-of-way, our streetscapes really transformed by the work of city planning and transportation. You will see now complete streets are meant to be the rule. We're putting in bike lanes in more and more streets. And we're using, actually, our commissioners of planning and transportation went to Copenhagen and to Europe for a tour. And they used to paint the bike lanes. They used to have, the sidewalk, then the parked car, then the bike lane, and then the traffic. And they went to Copenhagen and to Europe and came back and painted it like this. The sidewalk, the bike lane, a little bit of a painted buffer between the parked car and the bicycle lane, then the parked car, using the parked car and a bit of paint as essentially the protective mechanism, right? That costs nothing extra than the paint needed. And then your cars. And then you can see the bus-only lanes for bus rapid transit. Where we have insufficient open space and in terms of parks and playgrounds, either building and creating more of those or also using pedestrian plazas as a way to generate more open spaces that will bring people out and pedestrianize the street. So here you can see in Brooklyn a really small pedestrian plaza that was created, very inexpensive. Paint and plant potters, basically. And when Pedestrian Plaza program first started, people were nervous. They were like, oh, will this work? Will the public like it? And we basically said, it's paint and plant potters. If they don't like it, let's pilot it for a few months. If they don't like it, we can always take it away, right? And of course, when you put public realm infrastructure out there, if it's well designed, people come out. They sit, they meet their neighbors, they love it. And so it wasn't going to go away. Many of these have remained permanent. and very inexpensive. And you could see that instead of a structure only for parking, you now have a structure for people on the streets, people walking to those elements. And you can actually use them on dangerous intersections as well. Sometimes you have weird intersections that are actually very dangerous. You can basically say, we'll create a pedestrian plaza there so that you can actually control it more. Also in our big plazas that you've heard about, Times Square, right? You had many people on the streets. Most of them were pedestrians actually, but 89% of the space were for cars. We basically said, you know, we're gonna address this by putting in a pedestrian plaza. Again, what will happen to retail, what will happen, and we said, let's just pilot it for a few months. It's only paint and plant potters and a bit of street furniture. And of course, this is what's been shown in our various pedestrian plazas. So evaluation is very important. Pedestrian volumes up, even though pedestrian volumes are already very high in those places. And then economic issues that many of the retailers are concerned about up in Times Square. Union Square, where we've increased our pedestrian plazas and better designed them, 49% drop in vacant storefronts, and that's compared to 5% drops across the city. Some other things that have been done. Our Department of City Planning basically noticed that, so now, you know, everyone's really thinking about pedestrians, bicyclists, transit users, and they noticed that in our residential streetscapes, very frequently, the sidewalks were interrupted by driveways, and that they could actually use the zoning text to very easily change that by clustering the driveways. And so they made this amendment to cluster driveways so that the flow of the sidewalk would be less interrupted by basically car driveways. Also, when car share became available, City Planning was critical in actually writing the zoning amendments needed to park these cars and find locations for these cars. Studies show that car share vehicles eliminate demand for private cars, and you can decrease the numbers of cars on the roads on a regular basis using car share. Our bicycle networks have increased by hundreds of miles in recent years. Bicycle infrastructure that complements those bicycle lanes, bicycle parking, both indoor and outdoor. For indoor, Transportation and City Planning worked on a bicycle parking law that has now made new construction must now have bicycle parking, indoor secure bicycle parking as a part of the developments, both commercial properties and residential properties. Now, one of the issues, of course, is the developers were concerned that this would eat into their available rental space and tenant space. So City Planning was able to change the zoning such that the area of the indoor secure bicycle parking did not count against the developers. So that area was discounted from the total area that the developer would be allowed to build. So this combination of mandates plus incentives are sometimes important to pass your legislation. Bike share coming to New York City, when it does start this year, it's supposed to be the biggest bike share in the US with 10,000 bicycles, 600 stations. Health is involved with transportation on the evaluations related to health. Land use mix, so I talked about the importance of fresh, healthy food. Yeah, and should wrap up soon, I think. Okay, fresh, healthy food. So tax and zoning incentives, health, city planning, economic development got together and basically said, how do we create incentives for supermarket development in our high needs areas? These are also areas in need not only of fresh food, but also of jobs. New supermarkets provide jobs, and so we've done that. Land use mix. So this is the High Line is an old abandoned railway for many, many years that the city rezoned, put some economic investments into, and has redeveloped into this walking park, beautiful. Apparently we've reaped back the economic benefits through the real estate and retail taxes many-fold. And this is a picture of the High Line. We're developing the waterfront, both for access to recreation on the water and next to the water. And many of these greenways also serve as active transportation corridors. We've been programming our streetscapes through summer streets and play streets. So these are street closures, modeled after the Bogota's ciclovias. So in August, on Saturdays, a 7-mile stretch of Park Avenue is closed from Brooklyn Bridge up to Central Park at 72nd Street, connects into that 6-mile loop in Central Park, and Health's been involved in the evaluations. You can see here, people came out to Summer Streets, meeting about half of their weekly recommendations on the Summer Streets route, but 90% coming out through active modes. And we found, though, that people in the outer boroughs, particularly some of the high-needs neighborhoods, were underrepresented. And so we went back to transportation and said, hey, you know, how do we expand this to actually serve the needs of people who actually are suffering from health disparities and the highest health disparities? And transportation said, you know what? Not feasible for us to actually expand the route into some of our highest needs areas, because those routes would be too big. Police presence at the different intersections too costly, particularly in this budgetary climate. But we can create a new class of permits that creates single blocks of street closures on quieter streets. That can be done in all of our neighborhoods. And community groups and schools who don't have enough play space can actually apply for these permits. Health provides a coordinator to help them apply for these permits. Transportation approves these permits. And then Health, you know, is undertaking evaluations. You could see the majority actually would have been inside or watching television if these play streets were not present. Stair promotion, we talked about that. Improving tap water access in your public realm, in the buildings as well. The buildings actually, we've passed now a new law as part of the whole set of proposals to green our construction codes. So packaged with the water efficiency proposals was a proposal to improve tap water access in worksite buildings. In addition to legislative processes, there are administrative processes that can be used. So for example, the design and construction agencies all have their own design and construction standards that they give out to their project teams, to their contractors. Health elements, like the active design strategies, can be incorporated once you've developed a relationship with these other agencies. These are changes that can occur with no legislative change, merely an administrative ones, once you have allies in these other agencies. Training can occur for the staff in the other agencies. Health garnered a grant and actually developed the trainings and then worked with the leadership to train the staff in the other agencies. Our grant has now expired, but our Mayor's Obesity Task Force has now funded a trainer for the city to continue this work. So health grants actually can be used to stimulate as well positions that are later then funded by actual sources in the city, even outside of health. Also, green buildings and green development rating systems are a really potential good way to integrate health. Often health is already cited as one of the outcomes. Sometimes, though, the health elements and factors addressed are actually not sufficient to address the types of health issues that are priorities to public health. But by working with these entities, there are opportunities as they update their criteria over time to insert health elements into their greening systems. And these are systems that are already used very frequently by the development, architectural, and planning worlds. And so it becomes a part of the tools and compendiums. United States, over 50 communities, all 50 states have been funded in the last few years to actually undertake work to create policy and environmental changes to address obesity and tobacco. The vast majority of these are addressing work around obesity because of the gains we've made in tobacco. New York City has been mentoring. We got an extra grant to mentor 14 other US cities across the country on these issues. These are the types of partnerships you see across the cities, with health planning, transportation being key, but also school construction, parks, public works, housing, and buildings. And these are the types of impacts we've been able to achieve in actually a relatively short time of concerted, comprehensive efforts in New York City. Pedestrian volumes up at places that already had high pedestrian volumes, stair use where interventions are done, commuter cycling up nearly 300%, bus and subway ridership up despite already high previous rates, increased places for children's play. At the same time, decreased traffic fatalities, decreased traffic volumes, decreased car registrations, reversing the childhood obesity for the first time, both in New York and in our mentee cities of Philadelphia and San Diego, who also take very comprehensive approaches, and of course the positive environmental and economic impacts. Sorry I went over time, I'll stop.
Thank you, Karen. I don't think you need to apologise. I'm mindful that we advertised this seminar as going till 10:30, but I noticed not a single person moved as the clock passed that time. I think we might be indulgent and take about another 10 minutes for any questions and answers, but I do understand, and I'm sure Karen will, if people do have to leave. But if you're willing, we could just take a few minutes of a Q&A. Before everyone goes, though, I just want to interrupt with a little thank you. I omitted to acknowledge NHMRC at the opening, and to thank them very much for allowing us to use this room today. So if anyone's here from NHMRC, we'll certainly be thanking Warwick and partners, but I did want to just make sure we acknowledge that. So Karen, stunning talk and some very inspirational stuff there, but I think also very grounded in the realities of the hard work that you've done and particularly I think for many of us here, the realities of building those partnerships and consultation and the acknowledgement of the time that takes, which many of us often feel deeply frustrated by, but I think you're showing the results of taking that approach. But rather than my commentary, if anyone has any questions, please feel free to show your hand and introduce yourself to Karen.
Can I actually start by making a comment to your comment, Lisa?
Yes.
Which is, you know, the energy that it takes to create the intersectoral partnerships. And I think you're absolutely right about that. For example, the New York City Health Department had been wanting to undertake this work actually for some period of time before I came on. But in order for us to actually make traction on the work, they actually physically had to create a position, initially my position, one full-time position. Well, initially it started as part of my time, but as the work grew, they allowed it to become my full-time position. So you need actually dedicated staff who are initially, I think, funded by health to go out there to do the outreach, to make those partnerships, to and so there is nothing like actually having dedicated staff to do this. And as the program has grown, the health department has given me staff needed. For example, when the active design guidelines came into play, I couldn't do everything else I needed to do and be the primary coordinator of those guidelines. So they were willing to give me a project staff, a project manager who would report to me, but coordinate that process. So the staffing in health is actually very, very critical, particularly early on. I think as you grow those partnerships and as this becomes a part of the lexicon of work with the other partners, you will start to see, if you're successful, positions being created in some of your other agencies. And we've started to see that now. So the healthy green development work, we originally funded with a grant for 2 years. The grant expired, and then Design and Construction, our public sector agency, public works agency said, this is really important, and we're going to fund a person now to basically work on this across all of our projects. So now and they can provide technical assistance to private sector projects too in the city who might need that help. So all of a sudden, you now have a permanent position in a different agency doing health work, right? And so, but initially, they didn't have the resources, they couldn't make the justifications. So initially, health had to invest, right, in the staffing in resources.
Oh, there go the hands. Yes.
Hello there. My name's Christine Lawrence. I'm with the ACT government. Your comment just then about the mechanisms of staffing were required and how you did outreach. A presentation on that obviously different mechanisms and processes would vary across jurisdictions, but hearing about the strategies that you went through to develop those partnerships, and did you go from top down or bottom down or a combination of both? I think a lot of us know what we need, but are grappling with the how do we go about getting that.
Yes. Yes, actually, in some of the other places where I had more time, I was actually asked to give a very specific presentation on the how. So the what's would be sort of a general presentation, and then, for partners interested, there would be a how type of presentation. Unfortunately, we don't have enough days here as posts.
To get you back.
Yeah, I do have a paper though that was written on on one specific process about development of the active design guidelines. So it's in Health and Place. Health and Place, February 2012. Yes. Health in Place, February 2012. There's a publication that I was invited to write on the process of developing the active design guidelines across the different sectors. So that gives a little bit, I think, flavor of from one initiative of how we develop those partnerships.
Okay, great. Yes, down the back. Yes, and then Lisa after that.
Hi, Annie from the Planning Institute. I noticed in Melbourne you were running a seminar on the food. You'd mentioned it about food in New York. What were you covering in that?
Oh, we covered a variety of things. Folks wanted to hear about all of the food things that were going in New York City. And the food policy work going on in New York City encompasses actually different groups actually at the health department. So there's a group dealing with what's inside food itself. So that trans fat bans, the sodium reduction initiatives, food standards and beverage standards for city agencies, served by city agencies, but also for vending that are on city agency properties, which are now actually being uptaken voluntarily by private hospitals and some of the private sector work sites. But it started really with focusing in our own house. Then we have another group that actually works on improving the food items within food stores. So examples of that would be, our corner stores. Many of our neighborhoods that are still underserved by supermarkets have these corner stores called bodegas. And in the bodegas, basically, they usually sell cigarettes, alcohol, chips, soda pop. If they sell milk, it'll only be whole milk. If they sell bread, it'll only be white bread. So there's a group working with them to try to improve the healthiness of what they carry. This group actually has also in recent times started to do outreach to community advocacy groups who then work with community residents as a second force to approach store owners to request healthier items to show demand. The other piece of that, of course, is our calorie labeling legislation, which deals with the types of information that you make available within food premises. And then there's the work that I do that I talked about in terms of the built environment work, which is about creating healthier premises, actual food stores or premises, working with other sectors like economic development and city planning in different neighborhoods. So that's the supermarket development, looking at community gardening opportunities. We've created a new class of permits called green carts. So basically, this actually came from our food sanitarians. They noticed that because they licensed the street food vendors. And they said, oh, you know what, there's a really long lineup for street food permits, right? And what if we create a new category? So our sanitarians have become involved in food issues because they help to enforce the calorie labeling and trans fat laws in our restaurants. So we don't create a whole class of other people to go in and enforce this. Our sanitarians who are already there doing food safety inspections will inspect for compliance to the trans fat bans and to the calorie labeling laws that we have in our restaurants. So because of their work, I think, thinking through chronic disease prevention issues, they actually proposed that maybe we could create a new class of street food permits called green carts that would allow this long waiting list of people the option to bypass that long waiting list to a new class of permits that would only sell fruits and vegetables via street food carts in our high needs neighborhoods that are food deserts. So those were some of the items that we talked about. And then, of course, the tap water access issue is part of the beverage access issue. So that was what was covered in that session. No, there are various papers in different places put out from the different groups.
We'll see if we can follow up on that and maybe put it up with some of the notice about this seminar. Lisa, you had a question?
Yeah, thank you for your very inspirational talk this morning.
Thank you.
I'm from the Institute of Health and Welfare, and making the case for investment like this and change like this is some of the things that people in this room will grapple with, and you have already done so. But really, I'm looking at asking you what the early evaluation has said about the program of work that you've done, and also where we might track that evidence over time to help support initiatives in Australia.
Yeah, well, I think as you know, as a health department, we clearly do undertake surveillance activities, health surveillance activities. So, for example, we have childhood obesity surveillance activities going on where in physical education class, we actually measure the heights and weights of every child every year. And it's because of that particular surveillance system that we've been able to show, have the data to show the reversals in childhood obesity that have occurred recently after increases. We undertake a yearly survey of 10,000 New Yorkers every year, oversampling the neighborhoods that are our highest needs neighborhoods that suffer from the highest health disparities. We actually complement that with actual evaluations that are done of specific initiatives. So when we launched our STAIR prompt initiatives, for example, as these the STAIR prompt signs were being put up in more and more buildings, we actually decided to take 3 buildings in 3 different neighborhoods, 3 different types of buildings. One was a 10-story affordable housing building, one was an 8-story academic building in Brooklyn, the third was a 4-story clinic building, one of our own in northern Manhattan, that we decided to evaluate to look for effectiveness of that particular prompt with that particular message in our particular context. And that paper actually is published in the American Journal of Preventive Medicine, again, February 2012. So we undertake evaluations of, like, for example, when we had play streets, when we have summer streets, right? We actually undertake evaluations of those specific initiatives, but we also have the surveillance systems, and we also complement the data with data being collected by our other departments, like transportation on traffic fatalities, on traffic volumes. And these are things that you also want to cite because politicians and different sector groups care about these other outcomes that are in addition to, and these are also health outcomes, like traffic fatality is a health outcome as well. So, so that's how we've been doing that.
The traffic fatality figure is quite stunning. Is that, what percentage of that do you know is cyclists? Because
it's actually gone down for cyclists as well as other groups.
Oh, okay.
Yeah, well, pedestrians as well. There's this concept that, as you increase the numbers of types of users on the roads, the suggestions that car drivers become more aware of other people besides the car on the road. Whereas if you only had like signage, like, speed limits, etc., it's easier to ignore. Right? But once there's actually a sufficient mass of people doing other things on the roads, then they're actually more cautious, I think, because they're aware there's other people besides the car. Yeah.
I think we're going to have to stop there. I'm sorry, but a smaller group of us are going to have a little discussion around research needs now, and I think we just need to give Karen a break, or we won't hit our schedule. But Karen, thank you very much on behalf of the University of Canberra and ANFA. I've got a small pin to give you.
Thank you.
As a memento of your visit to ANFA, and thank you all for coming, and I hope you go away suitably inspired.
Thank you.